Okay, welcome everyone. Leroy, I did hear that you was with us as well. I hope you're
Yeah, I'm
doing
here.
well, you and your
Yeah,
family.
yeah, I'm doing well. It got
That's,
cold. Got cold here today though.
I
So
know. Same here. I mean, it is really cold. I mean, I had to pull out my big coat and everything, but this is my favorite time of the year. Yes. Well, we'll go ahead and get started. We do have a lot to do tonight, and I don't want to um not have the time to get it all done. Let me let Krista in and we will go ahead. I'll go ahead and go over Dr. Stella's Educate is a Dr. Sellers Educated is approved as a provider of nursing continuing professional development by the North Carolina Nurses Association and accredited approval by the American Nurses Credentialing Centers for a Commission on Accreditation. To receive contact hours, you are required to stay for the entire program, watch the full recording, and complete the evaluation. So I just wanted to go over that. I hope everybody's doing well. Hi, Krista. How are you doing today? Good.
Good, good.
Good. Everybody's back. Awesome, awesome, awesome. Well, we're going to go ahead and get started. As you can see, we have a nice packed evening. We're going to do our 10 dictionary terms. We have chapters 18 and 19 on SPs and I think evaluation. And we'll then take our first 15-minute break. Then we'll come back, do quiz 20, break 21, and then we'll be done for the evening. We're wrapping it up. It's going by pretty fast. It may not seem that fast for you, but it is really going by fast. I do want to remind everyone, please make sure you look at the course cross mapping just to make sure if you have the Defining Excellence in Simulation program that you are going back. And if not, while we're doing it, it would be good to do it while we're taking the classes, to go back at the end of the session that you do and go back and crosswalk the material, what you read in the book, and then go to your Maxworthy Pallegana's book and read those other articles and other information and take a deeper dive into some of the concepts because it's really, really some good information and I know it'll be beneficial to you as well. Also, I have, I think just one document in week 5, but I have week 5, I have a document that I will be adding, and it's actually on standardized patients, the difference between standardized patients and Confederate patients. So what I'll do is I'll show that tonight once we get to chapter 18, and then we'll just look at it, but I'll make sure I put that in your folder as well. Okay? Everybody doing well? Any questions before we get started? We will do the same format as we do every night, every week. You will put your answers in the chat box and make sure when we answer, we want to be able to do our rationales or either at least say why your answer is correct, what in that question helped you or led you to choose your correct answer. Because that's what we're going to really, really want you to do. Not answering the questions for memorization, but answering the questions because you know what to do. You know how to answer them. Your CHSE exam is application, little knowledge base, but more application. How and implementation, application, and evaluation, of course. But how will you see these concepts laid out in your in simulation? And doing all the questions helped me. But the one thing I had to do was do the why. I had to do the why. I had to be able to explain why I chose that answer, and that really pulled it all together. So let's go ahead and look at, we're still in our simulation. We're still in the educational principles applied to simulation, which is 40% of your CHSE exam. This is the second half of that section. We did the first half last week. Tonight, we'll be looking at standardized patient debriefing and feedback. We'll look at evaluation of simulation activities. And then chapter 20 will be fostering professional development in healthcare simulation. And then chapter 21, look at role of the research in simulation. We've been throughout our the past weeks. We've been talking a little bit about each one of these. So I hope tonight you're going to see some repetition, and repetition is good. It's just going to present itself in some different ways. Okay. So let's go ahead and look at our dictionary terms. Pull those up. Dictionary terms. We have 10 for tonight. We'll start out with educator, simulation educator, clinical simulation professional whose responsibility is to develop and implement clinical simulation. Based education, that's who we are. That's what we do. Embedded participant, an actor who plays a role assigned in a simulation to help guide a scenario. An actor, embedded participant. And we'll look at some of that in this SP chapter as well. The role is assigned in a simulation encounter to help guide the simulation. The guidance may be positive, negative, or neutral. Environmental fidelity. It's another one of our fidelities. Environmental fidelity looks at the degree to which the equipment, what does that environment look like? What is it in the environment to make that simulation realistic and real? Cues distinguishing information as real, objective, what can they see, what can they perceive from the environment, and subjectively experience, perceptual fidelity. Environmental fidelity is to the degree which cues provide a duplication of the environment and motion through the environment. That's when we're in a hospital setting. If it's truly an ICU, you try to make that simulation room look like an ICU with all the bells and whistles, all the equipment that we have, to turn it into a nice simulation in critical care environment. Evaluation, making a judgment or determination concerning the quality of a performance, work, product, or use of skills. And when we look at evaluation, we do know formative, summative, and we have the high stakes. You also want to make sure when we're doing your high stakes, that you do have a valid tool. And even with any of your evaluations, you should have tools that have been validated. Making judgment or determination concerning to the quality, a broad term for appraising data. Evaluations is much broader. Measuring the value of the educational activities. Evaluations are critical for our simulations as well, because as we do our evaluations, we make sure we make the necessary improvements to our simulations moving forward. It is important for evaluation. Extended reality, talked a little bit about that when we looked at AI, VR. Virtual clinicals or virtual reality. It's an umbrella term that is a fusion of all the realities added together. Augmented reality, virtual reality, and mixed, which consists of technology, mediated experiences embedded via a wide spectrum, hardware. We can have AI in there, avatars, et cetera, merging graphical virtual environments with the real world. Facilitator, simulation facilitator. Educator is the one that's teaching, right? The educator, we're educators, and the facilitator actually facilitates that simulation environment. Hold on just a second. Let me let Miss Kristen in. She's waiting to get in. Sorry about that. An individual who is involved in the implementation and or delivery of the simulation activities could be faculty, educator, or clinicians. The simulation facilitator development should be guided by a set of common facilitator competencies, grounded in expert consensus and evidence-based practice. And we align that well with our NASCO standards. Facilitators provide feedback, which is also part of that learning process. Individuals who help to bring about the outcome. Our next definition for this afternoon is feedback. How do we provide feedback? Feedback, an activity where information is relayed back to the learner. Feedback should be constructive, address specific aspects of the learner's performance, and be focused on the what? Learning objectives. That's big. Learning objectives. Feedback can be delivered by the instructor. Our machines can. Some of the simulation. Some of the platforms that we use can provide feedback as well. I don't know if you're familiar with RQI. That's a simulated BLS mannequin, the adult and the child. They provide real feedback to the students in those simulation experience. So that would be considered like a machine, a computer, or a patient or a simulated person can provide that feedback. Fiction contract, explicit agreement between the learners and the instructors. We developed that in the pre-briefing stage, right? And the goal of your fiction contract is to disband disbelief, put it aside, and help the students accept the scenario as real. Effective execution of this agreement depends on equal involvements on both parties. That's the faculty and the students as well. But it is very critical for us to have that fiction contract during our pre-briefing, have the students understand. We have them sign as well so that we can disband or suspend disbelief, ultimately minimizing the blame that a learner can place on realism of the scenario. Fidelity, again, looking at the degree to which the simulation represents the real event. How real does this event replicate a real event in the hospital or wherever we're doing it in the workplace? This can be physical, psychological, and environmental elements. Fidelity in simulation is a multidimensional concept corresponding to the degree of realism. So when we look at our fidelity, low fidelity, high fidelity, how real is that simulator compared to a real person? Formative evaluation or formative assessments is our next term. And that's what we talked about, how we're forming learning along the journey of a student's learning journey. So how do we form that? By providing feedback, allowing them time to do deliberate practice while giving them real feedback so that they can form a sense of proficiency. Refers to tools that identify misconceptions, struggles, learning gaps along the way, and assess how to close those gaps. It includes effective tools for helping to shape the learning. It's a type of assessment wherein the facilitator focus is on the participant's progress towards goal attainment through preset criterion. We can use checklists, like in our skills checkoffs, and we're helping them during their open practice lab, providing them the feedback so that when they do their final validation, they're successful using those checklists. We provide that feedback, constructive feedback. Our next term for tonight, and I think that's it. That is it. So we're at the end of our 10 terms for tonight. All right, so let's keep moving. Hi, Kristen. Hope you're doing well. Glad you were able to join us this afternoon. Kristen, are you there? She stepped away.
Yes,
so we'll go ahead.
I'm here. My audio is doing something wild. Sorry.
Okay, that's okay. I'm glad to see you this afternoon. I hope you had a good weekend. The start of your week is going well.
Thank you. You too.
We will go ahead into chapter 18. We're going to do 18 and 19, and then we'll take a nice break, 15-minute break, and then we'll do chapter 20. We're going to start off with standardized patient debriefing and feedback. Standardized patients debriefing and feedback. We're on page 305, and our first question of the afternoon. Number 1, the novice simulation educator understands feedback when they state feedback is A, just another term for debriefing, B, one tool of debriefing, C, best delivered by peers, D, a process of self-reflection. That is correct. Who would like to tell us why you chose B, one tool of debriefing?
Debriefing could include student, providing them time to reflect. But hang on a minute. Simulated. Oh, but the question goes back to the educator, not to the learner. So feedback is would be another tool for the debrief also. So
Yeah, when you look at your, I'm sorry, Leroy.
I said that's what I interpret. So
Okay. So when you look at your choices, and the thing about this educator, this is a novice educator, right? This is a novice educator. So we're trying to see, do they understand what feedback is, right? What
right.
is
So
feedback?
the educator is not the one reflecting. The student reflects. If if I'm making sense on that. That's why I didn't pick reflection. That's why.
That's why you didn't put reflection, right? There's not a process of self-reflection. So you're correct. That would be wrong. So if the novice simulation said that that's what feedback was, we would know they still need some more understanding of feedback, right? But when they say best delivered by the peers, it's really best delivered by the facilitator, right? Peers can give it, but they just probably more or less respond to their behavior. But feedback is usually given by someone that is doing the facilitation and, even also have some idea what feedback looks like. Now, sometimes there may be peer to peer where they're actually practicing and giving feedback. For this question, that wouldn't be the correct answer. Then it goes to say just another term for debriefing. We know it's not another term for debriefing because debriefing does not mean feedback. It's a time where we do provide feedback, right? So the novice educator understands feedback when they state that it is a tool of debriefing. It is a type of method of tool that we use when we're doing debriefing. So that's what makes B correct and the other one's incorrect. Your rationale in the book says it is a debriefing tool that focuses on providing learners with information about what they did well and what competencies need improvement. It is not another term for debriefing and is not usually provided by peers. Feedback is given by another person so that it is not a process of self-reflection. And that's what you were talking about, Leroy. Number 2, the simulation educator prepares the learners for debriefing. The simulation educator prepares the learners for debriefing. A, to teach them debriefing methods and tools used in the process. B, as an optional formative peer evaluation process. C, as a summative self and quality improvement tool. D, to assist them to participate more effectively in the process. Yes, our answer is D. Our answer is D. So, Krista, can you tell me why you chose D? Would you like to share why you chose D and didn't choose the other ones?
Yeah,
What was your thought process?
I chose D because so we're preparing the learners. So
Uh-huh.
in preparing the learners, we're helping them to figure out how to move through the process of the sim.
Right.
Looking at, as a summative self-assessment, well, how is that summative? But a quality tool was where I was like, that one's not going to be a quality tool. Summative self-assessment maybe, but the quality tool part, quality improvement tool, that was where I was kind of like, no, I don't think it's a quality improvement tool by preparing them for debriefing. I think that was the biggest part for me. How am I preparing the students for debriefing?
There you go. There you go, right there. This asking how or the simulation educator prepares the learners for debriefing. We're preparing them for debriefing, not as a summative self, because it's not a summative self, right? And as an optimal formative peer evaluation process. No, it's not optional, is it? Debriefing, you need to debrief after you have a simulation to teach them debriefing methods and tools used in the process. No, that's not what debriefing is all about. So we want to prepare them. So in essence, I was looking at this one to keep the psychological, keep that environment safe. So to assist them to participate more effectively in the process. So if I prepare them about what to expect in the debriefing, then you should have, hopefully the students will stay safe and they'll see that this is a time of learning and not a time that I'm going to be really judged in a negative way to I can't learn or change the behavior. Because remember, if we break psychological safety, they're not going to learn. And the behavior that you want to change, they're not going to be open to being honest either about the way that they felt. So when you look at your options to assist them to participate more effectively in the process, that's one of the reasons why we do want to prepare them for the debriefing process. Hence, we do that as we move throughout. We especially do it in pre-briefing, but you remember we had a question, I think, last week that even talked about reorienting, or the question say orient. Out of those choices, that was the one to choose because right when you get ready to go into briefing, you want to remind them this is a safe time. This is a safe space. You know, you have safe space. What happens in simulation stays in simulation, and what's going to happen in debriefing stays in debriefing unless there's concepts that we need to move forward to your faculty. We'll do that in a healthy way as well. Thank you, Kristen. Thank you so much. Debriefing works best when learners are part of and engaged in the process. Learners do not need to know the difference between debriefing methods and its own, and it is not a peer-reviewed process. Reflection and self-improvement are part of it, but students need to be prepared to participate in self-reflection and improvement. Because if you don't prepare them, and if you do it in a negative way, they're not going to feel safe to self-reflect. And guess what? They're not going to improve their behavior. 3, a standardized patient would like to participate in debriefing with the simulation educator. The simulation educator understands that A, every SP has been educated in debriefing. B, debriefing is more difficult in communicating an assessment. C, debriefing is more used than just giving feedback. Or D, debriefing is a complex activity for SPs to master. Correct. It is. And we already know that's not a role of the SP to debrief. What is the role of the SP when we think about the debriefing and when we get the evaluation? How do they help us?
More feedback than anything.
Exactly. More feedback. Correct. And that is done in the debriefing space. Providing feedback, and they need a tool, right? Usually they have a tool, a structured tool that we can give them to help them guide their their observation of the students and their feedback using their tool. So correct. Debriefing is a complex activity for SPs to master. Every SP, has not been educating debriefing because that's not their role. Debriefing is more difficult than communicating an assessment. Debriefing is more than use than just giving feedback. Debriefing is a complex skill, and not all SPs are prepared to conduct debriefing. Not all SPs have debriefing education, and it is just as valuable as feedback. It is. Communicating assessments is also complex, but it's not the main objective of debriefing. So there again, they're looking to make sure you understand the role of the SP and also a split concept, making sure we understand debriefing as well and what happens in debriefing and who are the leaders in debriefing, who are the participants in debriefing. And it going even back to our fiction contract as well. Number 4, the reason standardized patients provide feedback on communication is because A, they are in the best position to judge learner communication. B, it is easier to evaluate communication than the physical assessment. C, they are trained and practiced to provide feedback. D, they are trained to assess therapeutic communication. And remember, choose, what is your best choice there? Yes. Why did we choose A? That is the correct answer when you look at all four choices. So why did A stand out?
Because the SP and the learner, they're communicating, or they
They're
should
able.
be communicating. Yes.
Mm-hmm.
And they can, the SP may be able to see more nonverbal cues, facial expression, what have you, than the facilitator, watching with a monitor, what have you. So.
I love it. They're in that best picture. And I didn't like the word judge, but they have it in that sentence anyway. But yes, you are correct. They are in the best position to provide that learner communication because they're actually learner real feedback, nonverbals, just like what you said. They are in the best position to judge since they are the recipients of the care and the interaction. All assessments are difficult and SPs are educated and trained in their role, which can or cannot include scripted communication. SP, standardized patients. SP, standardized patients. 5, the simulation educators debriefing a student after the student performed a physical exam on a standardized patient. The most productive debriefing method include A, telling the learner directly what they need to improve. B, showing the learner how the physical assessment should be performed. C, asking the candidate to retry the exam and correct as necessary. Or D, letting the SP debrief the learner after the physical exam. B is your correct answer. So tell me why we chose B. This one could be a little tricky, but it said the most productive way to debrief. The most productive. B is
Yes.
correct.
Don't debrief, right?
Mm-hmm.
So I would
Okay.
not say that is correct because it's saying that the SP is debriefing.
The sim educator is debriefing. The simulation educator is debriefing a student after the student performed a physical exam on the SP. So the educator is doing the debriefing, but they're debriefing that student after they did a health assessment on the standardized patient. So they're saying, what is the most productive way to debrief that student? Tell the learner directly what they need to improve. You need to improve that. You didn't do your eye exam. You didn't do that right. You didn't do that right. Is that the most productive? Or asking the candidate to retry the exam and correct as necessary, meaning while they're doing it, the exam, you stop them and say, no, do this, do that. Or letting the SP debrief the learner after the physical exam. And we know that's incorrect because SPs don't debrief, right? So that leaves us with showing the learner. That would be the most productive because if you can show them, especially with a health assessment, right? Showing them what they've missed, guess what? That's formative as well. Then they're able to correct that assessment and do it correctly as they get ready for their summative evaluation or their OSCE, depending on what type of student it is. So showing the learner how the physical exam should be improved, telling them it could be an option, but your best, most productive one would be to show the student, especially with a health assessment exam, right?
Is that really because this has to do with like a skill, essentially? Like assessment is a skill. So showing somebody how to do it is better than any of the other
Ex-
options. But if we were talking about like anything outside of a skill, to me, debriefing doesn't, you're not supposed to be like teaching the student
No, you're
something.
not teaching. And see, the key about that is in your debriefing, you're not teaching, but you'll ask those type of Socratic questions that will help open up. Well, I noticed
Right.
that you paused, right?
I just
Mm-hmm.
think that this is, to me, this is an odd question because I don't think about, I mean, if you're showing somebody how to do something in a debriefing, to me, that's teaching, which isn't the goal of debriefing. But I'm assuming because this is a skill that you're debriefing, it's different than you would be debriefing some type of scenario situation. Is that
Yeah,
where the
and
thought process is?
this could be an OSCE. This could be
Okay.
a med student. This could be a simulate experience in health assessment. So you would have to show them the correct, and it is a skill. Again, yes, psychomotor is a skill. So the best way to correct that behavior would be to show the student, just like if you're doing a Foley insertion. You know, you can let them go through practice or go through through the practice session. Sometimes when I let them go through and then I provide them feedback at the end. So again, it is a skill that needs a type of debriefing, but the best way to debrief that student, like you could tell them what you saw, but you got to have a point where you have to demonstrate it so that they can correct their behavior and get the skill right the next time. And I see what you're saying, Kristen. But telling the learner directly what they need to improve without giving them a demonstration is useless, really. But the best way to do it would be to show it to them.
Oh, absolutely. Yeah, I get that.
Let's see what your rationale. Demonstrating a competency is the best way to ensure learning. Telling the learner directly or asking them to retry may not produce the correct competency. The SP is not the best person to debrief healthcare competencies because they are not trained in feedback, but not always in the debriefing techniques. Or they are trained, let's see. They are trained in feedback, yeah, but not necessary debriefing. Number 6, the advantage of using Pendleton's rules for debriefing is that A, it helps both the standardized patient and the learner prepare for debriefing by listing positive performance and tells the learner what to do differently. B, it is an easy technique for SPs and simulation educators to remember and repeat as often as needed. C, research shows it is an effective debriefing process and produces immediate improvement competencies in learning. And D, learners like to get both positive and negative feedback in that order and build confidence in skill attainment. You are correct. That's correct. Our answer choice is A. Would anyone like to tell us why A is correct? Because it's one of Pendleton's rules for debriefing. What makes B, C, and D incorrect? Now, what was your reason for choosing A?
For me, B, it's not including the student or the learner in that question. So it's focusing most only on the SPs and the indicators. So that's why I didn't go with that one. And then the improved competencies in learners, it's not, it doesn't, immediate is just, it turned me off on that one as well. Cause you're not gonna, you may not see immediate results. They may have to read and you know, watch again or whatever.
Right.
And then learners getting both positive and negative feedback in that order, that sounded like more like that sandwich theory.
Yeah.
That's why I didn't pick that one either, which just left A.
Okay.
Yeah.
Okay.
And then Pendleton's rule is you start with a positive and then lead into a discussion. And A fits that also.
Fits all of the fits it well. Prepares Pendleton's rule help prepare for debriefing and provides a debriefing process. The technique is not necessarily easy and does not produce immediate results. Learners usually do not like negative feedback, which they don't. That's why we have to be very strategic and trained on how we even provide that negative, or we call it constructive feedback. And I love you brought up about the sandwich, because that is one good way too to provide that feedback. You know, start off with a positive and then address the behavior of concern and then follow it up with another positive to actually provide the student a nice, safe feedback, constructive feedback that will protect them and hopefully lead them to a change in behavior and understanding. Number 7, the simulation educator can best ensure standardized patient debriefing quality by giving the SP feedback about the debriefing. B, asking the SP to self-assess their work after reviewing the videos. C, questioning the SP about their knowledge of debriefing. D, using a debriefing quality assurance checklist to note SP behaviors. Yes, our answer is D. Who would like to tell us why D is your correct answer? Or why the other three are not correct?
I think the glaring word is a checklist
That's right. You remember, yes,
for
checklist
the
for them.
SP.
Yeah, a checklist for us for the SP and checklist for the SP for the learner. Correct. Because if you have that checklist, you could actually go down it and actually it'll have, and it has very structured or consistent behaviors, right? And you're able to really speak to the checklist, giving them SP feedback about the debriefing, asking the SP to self-assess their work. It says, how can they best ensure SP's debriefing quality? And if we have any checklist, it really takes the quality of that assessment evaluation time to a very high level. So you're correct. It measures effectiveness, also standardized feedback across the SP community. SPs can understand the learners. A checklist ensures consistency and is a good method to audit the SP interactions. Feedback helps and does, as does self-assessment, but a checklist standardizes that whole process. Correct debriefing techniques. Questioning the SP directly does not assess the debriefing behavior. And remember, they're not debriefing, but it's how we are debriefing them on their interaction within the setting as well, and in their behavior as being a standardized patient. 8, an effective affective attribute of healthcare providers is empathy, which can be demonstrated in simulation by the standardized patient understanding the learner's frame of reference, SP acting warm and caring toward the provider, creating a psychological safe space and culture for the learner. D, an adult learner approach where the SP holds the learner accountable. An affective attribute of the healthcare. Yes, the correct answer is A. A is your correct answer. Tell me why. What is key?
That the SPs are understanding the learner.
Mm-hmm.
That was what
Uh-huh.
yep, we're focusing on the learner here, so that's why I went with that one.
And it's the learner's frame of reference. When they talk about frame of reference, what is that talking about? Because we need to go ahead. I'm sorry.
Objectives.
And where are you? Where are they thinking, right? And that's very important for us to know. That's why we ask our questions as well in debriefing. Help me to understand. I saw you, you were a little hesitant, so please help me understand what you were thinking at that time. The SP can understand the learner's perspective and role model empathy for the learner. Empathy is more than caring. Creating a positive learning environment is part of empathy. It is not an attribute specifically of adult learning theories. What were you thinking? Help me to understand what you were thinking. Number 9, the simulation educator promotes a reflective debriefing model in order to A, promote positive learning, B, provide appropriate feedback, C, promote self-assessment, D, provide the standardized patient time to reflect. C is correct. C is our correct answer. We're providing them an opportunity to do what? Self-reflect. Exactly. Self-assess. Self-assessment works because then we can look back on our behavior and it helps us change. Same, it works with your SPs as well. Promoting self-reflection in learners will assist them in their lifelong profession to continue to grow and refine competencies. It does promote positive learning and provide feedback, but this is not the main goal. It does not necessary promote time for the SPs to reflect. And now last one for this section on SPs, the novice simulation educator needs additional understanding when they state that using the sandwich style of feedback, okay, Krista, A, makes learners active participants, B, can work well as reflective feedback, C, is congruent with physical examination debriefing, and D, places debriefing in charge, of what to discuss. Correct. A is our answer. There again, we have some nice psychological safety being maintained even when we're providing constructive feedback. What was positive behavior versus that behavior of concern, following up with some positive behavior will keep the students active. It can work well with competencies and reflection, but it does place the debriefing control of the conversation. It's a type of feedback. It is passive learning, not active. SPs. There's a nice chapter or two in your book. They're defining excellence in simulation on standardized patients as well. We're going to move on to evaluation of simulation activities. Chapter 19. We're on page 323. Make sure you review Kirkpatrick's levels and how they look in simulation. You have a resource document that talks about that. Oh, I was going to show you the SP versus Confederate. I did want to bring that up before we went to evaluation. When we think about standardized patients, those are patients. They are scripted and they stay within the parameters that they're supposed to through their training to help the students meet their learning objectives. So your Confederate role is different than your SP. Your SP role, they're standardized individuals who have been trained to consistently portray a specific medical condition, history, or set of symptoms in a unified manner. Okay? When you look at a Confederate, on the other hand, it's an individual who plays a specific role within the sim, but they can be other people. They can be family members. They can be healthcare worker, colleague, another nurse, or I did say family member. So there is a difference between your standardized patients and your Confederates. I just wanted to bring that up, and I'll put that inside of your folders as well.
Is the Confederate term the most up to date term, I suppose, I guess is what I'm asking. Like, we use standardized participants as opposed to standardized patients when there's somebody acting in a role outside of the patient. So I was just I've never heard that term Confederate before.
You haven't? But this
No.
was your term Confederate. Let's go back and I'll double check that one in our simulation dictionary. It's been a used term. But just wanted to make sure, because sometimes when you see Confederate versus your SPs, it can be a little confusing as to what you need to know the difference in question and in case study for when you go to choose your answers.
Thanks.
And you said, what was the term you used? I'm sorry. Say your term again,
when they're not patients, they're standardized participants as opposed to standardized patients.
I will look up your standardized participants. Yeah, because I used standardized patients a lot, but standardized participants.
And we do too. We call them standardized patients if they're playing patients, but if they're not playing patients, we call them participants.
For your standardized participants, for your Confederates, even though they're not consistent, because their roles can flex. I think a standardized being one that is more structured and consistent.
I think
but I mean, it warrants us looking at it.
Still comes with like the education for the SPs. I mean, they may not be playing patients, but they're still playing different roles that require their that standardization of how they're playing in that role. I don't know. I'm just
that warrants looking at it. Could be very confusing when you think of SPSP. So you're
Oh,
really
for
going to
sure.
have to make sure that you write it out. This is a standardized patient versus a standardized participant, and making sure that they really understand their roles when you're using. But that, I wrote that down. Yeah. Yeah. Because your Confederates are a lot different than your SPs or your standardized patients. Okay. All righty. Let's go to page 323. Thank you, Kristen. I'm going to have to research that one. Anybody have any other comments regarding what Kristen stated? How do you use SPs in your programs and Confederates? Anybody?
Yeah, we use SPs.
Standardized patients.
Yes, standardized patients, but I think we only have one or two scenarios through, it's a 5 semester program that we have the family members in there.
Mhm.
But we just refer to them as family members.
Right.
But I think earlier when we first start meeting with you, I think you used the word Confederate before. So first week or second week or whatever it was.
Yep. Okay. Good,
But
good, good.
but
Good.
I'm with Kristen. I don't think folks use the term Confederate. I don't know. So
Because you know what the controversy was whenever there was a lot of things governmental wise and then there was some issues, it can be very controversial. And I do remember those conversations when they were looking at changing their word terms to make it more neutral so that it really doesn't provide any controversy.
yeah, triggers. Yeah.
Triggers, exactly. And so yeah. I do remember that conversation a few years ago. It hadn't really been that long, to be honest, probably within the last, 5 to 6 years, if that. And it could be more recent that that conversation did come up. So I will go back and fact check that and bring that information. I'll actually do it during our break.
Okay.
Because people, like you said, it triggers some unhealthy feelings. So I will get that fact check. So we're at 323 on page 323. The first one is a faculty member is planning a formative simulation activity. When is the best time for this activity to occur? A, at the beginning of the course before any learning has occurred. B, near the end of the course, but before the final evaluation. C, shortly after the content has been taught in class. D, as part of the final evaluation and grading process. Okay, yep, our answer is C. Can someone explain to me or tell me why you chose C? I would see your answer.
Well, I can say that it's definitely not A, because you shouldn't be expecting students to do skills and things that they've not learned, or be involved in scenarios with content they haven't learned. D is a summative assessment, not formative. And I mean, B doesn't really make sense, because if they learned something near the beginning of the course, you shouldn't wait all the way to the end to do a formative evaluation on it.
So what is this question asking? Is trying to figure out if the faculty member really understand what formative simulation is or what formative activities are, right? And when you think about formative activities, they are forming learning along the way. So you're correct. At the beginning of the course, before any learning has occurred, there is you got to have something to happen first for them to demonstrate, for you to provide that feedback, right? And yep, near the end of the course, but before the final evaluation. And then shortly after the content has been taught in the class, that's your best optimal time. And remember, it said best. your best time. Learning and evaluations are not the final grades, formative learning, and are best done after the content has been taught in order to reinforce the knowledge. It should not be done at the beginning before there is an adequate grasp of the knowledge. Student has to display something. Miller's pyramid. How does that look when we see it rolled out in simulation? Number 2, a faculty member plans to evaluate simulation participants according to Kirkpatrick's level of evaluation in order to determine that the participant has reached level 4, what should be the focus of the evaluation? A, B, C, or D? What should be the focus? D is correct. D is correct. Please tell me, Leroy, why did you choose D?
I think for A, with Kirkpatrick's level of evaluation, that'd be kind of like level 1. They're satisfied with the experience.
Mm-hmm. That's good. Okay. And
Uh,
B?
Participant perception of learning. I'm going to guess that's 2. And then if there's a change in the behavior, that would be the 3. And I answered D though. So it's a change in the outcome. To me, I'm just trying to think the steps of that. So I think D would be the better answer because of the change in the outcome.
Mm-hmm. Because you remember level 1 is what? The reaction phase, right?
But you have to have a change in the behavior before you can have a change in the outcome. So
And the outcome. And D is correct because level 2 is your learning. When you look at Kilpatrick's level, you have your reaction. How are you feeling after doing this? And then number 2, your level 2 is what did you learn? Number 3 is when you take them and you see that behavior change. And then number 4 is what are the results, the outcome.
And that's where
You
they
are
apply
correct.
that.
That's the-
They apply that from the simulation to practice.
Exactly. Simulation to practice, because that's what we're doing. That's the purpose of simulation, right? Increase safe patient outcomes, right? We want to promote safe patient outcomes. So we put our students in simulation to help recognize those gaps, recognize those unsafe behaviors so that when they go back out to practice, we're able to practice safely.
Okay.
The 4th level, Kilpatrick's learning achievement theory is application in the clinical area or translation to practice. The 1st level of Kirkpatrick's level of learning is reaction to the simulation, which would be satisfaction. The 2nd level is learning, and the 3rd level is change in behavior. So make sure we understand what that looks like rolled out in practice. And you do have a resource sheet that talks about that as well. Kirkpatrick's level. 3, a faculty member has asked where to begin in creating an effective learning evaluation for their planned simulation learning experience. Which of the following would you say is the first step in this process? What is the first step? A, B, C, or D? Correct. It is B. Identify those learning objectives to be evaluated. B is your correct answer. Yes, yes, yes. NASCO articles. We look at those NASCO standards, and I'm telling you, hands down, identify the learning objectives. Start with learning outcomes that need to be accomplished. Use a reliable and previously used evaluation may work if the evaluation aligns with what the student learning outcomes, simulated based learning activity or experience should be at the right level for the student learning, but the student learning outcomes should be leveled so that it is known. Number 4, which situation would be most appropriate to use a checklist type evaluation instrument? A, B, C, or D? Checklists. That is correct. A is correct. And why would it be most appropriate to use a checklist for A?
Step by step.
Mm-hmm.
So
Step
because
by step.
or steps that you have to take. So a checklist, you can check off each of those steps as they're happening.
Mm-hmm. Mm-hmm. Mm-hmm.
And I feel
And
like
it's really good.
oh,
Go ahead. I'm sorry.
sorry. Oh, I was gonna say the other ones like B and C seem more like clinical reasoning or like judgment instead of like an actual skill that requires a step-by-step checklist.
Mm-hmm. Good, good, good. Because even formative assessment of resident ability to, achieve accurate differential diagnosis, high stakes. You're so correct. Affective domain, cognitive, but we're looking at that psychomotor domain. And when you're doing assessments in the psychomotor, the best type of evaluation tool to use would be a checklist. It really, just as Krista says, provides those steps, but they're really good tools. Your best tool really for evaluation of a psychomotor skill. What were you going to say, Leroy?
D is a affective domain. So the
Exactly.
communication.
It sure is. And checklists checklists work well for your psychomotor domain.
Yeah.
Inserting a Foley is a procedure that lends itself to a checklist. Psychomotor, the skill, the ability to recognize a deteriorating patient is clinical reasoning and does not lend itself to checklists. Differential diagnoses are done using clinical judgment and an algorithm, not a checklist. Communication is an affective skill and it's difficult to categorize on a checklist. Psychomotor skill, checklist is your best choice for evaluation. Your best instrument of evaluation. 5, a simulation educator setting up a new summative evaluation and wants to ensure inter-rater reliability. The best method to ensure interrelated reliability would be A, B, C, or D, and why? C is correct. And why is C correct?
You have two evaluators trying to read this using the same instrument.
There you go. That's exactly right.
So yeah, it's what face validity. I think that's the term for that. So if
Who?
I remember right.
Who?
Wait, no, I'm sorry, not face validity. It's just validity. So I'll take the face off that. Face is if you ask somebody else or the student tells you the answer is miskeyed or whatever. So yeah, that's how I remember that. Anyway, I'll digress.
But what makes that one stand out of all your other ones? You have two facilitators evaluating a simulation using what? The same instrument. That is what will ensure inter-rater reliability. Okay. And that is very critical for our summation or our summative assessments.
Yeah, A's that's obvious wrong. So.
That's exactly right. We have two students. That's right. Evaluating each other. Okay, good. Okay. And then you have two different ones. So inter-rater reliability can be confirmed by two evaluators looking at the same tool.
Right.
Same scenario.
B could be correct, but they ask what's the best. So.
Mm-hmm. The same scenario, evaluating the scenario with a single evaluation form and then comparing the results. Students are usually not responsible for summative evaluations. A checklist can still be subjective if it is not validated. Using different instruments does not assist with inter. Reliability. 6, additional rigorous research and evidence-based practice appraisals are needed to ensure A, B, C, or D. Hmm. My correct answer is D, and tell me why. And tell me why.
Ensuring safe patient care is the overall goal of simulation.
Mm-hmm. And that's one that we need more research on, and we think about Kilpatrick's levels as well. That's that level 4 where you really don't have a whole lot of research that supports that. Okay. Level 4, what are the outcomes of patient care? Long-term studies are needed to ensure that simulation is positively impacting patient care. Evidence demonstrates that students' perceptions are positive and that the faculty is competent in meeting student learning outcomes, but we still need more research in the other areas. Number 7, an expert simulation educator understands that a high-quality simulation learning experience should begin with A, B, C, or D. Hands down, clear learning objectives. And we all know that to be correct. Always starting with our learning objectives. 8, when choosing an evaluation tool for a simulation learning experience, it should reflect A, B, C, or D. Yes, the learning domains. And what are your learning domains again? That evaluation tool should be reflective of the learning domain that you are evaluating. And what are your learning domains again?
What's it? Cognitive,
Mm-hmm.
affective, psychos.
Psychomotor.
Yes,
Psychomotor is looking
yeah.
at what? Evaluation of
Skills,
skills,
manipulating things, using your
and the
hand.
affective domain is evaluation of what type of?
Well, feelings, your values.
And then when we look at the cognitive domain,
Knowledge, but that's not a good.
the process of knowledge, how are they processing knowledge to come derive to their answers or behavior?
Mhm.
The cognitive, the understanding, the process, and how they're critically thinking about it and pulling the thoughts together, the concepts together to produce their behavior or responses. Number 9, needed simulation research should be focused on which level of evaluation? A, B, C, or D? Again, we're moving back again to those results. D is correct. And Kilpatrick's the impact on patient outcomes, and that is D, your level 4 results. And 10, an educator wants to evaluate learning that ultimately impacts patient care. What level of translational research should be the focus in the evaluation of the evaluation? You think about translational research. Or translation, it is C, T3, correct. T3 looks at the results of the patient's outcome. Because impacts on patient care, again, is going back to your patient outcomes. Okay. Evaluation. Again, there's more in-depth in read inside of your book on evaluation. This is 40% of your CHSE exam, looking at the different ways that we do evaluate, formative, summative, looking at those again in case study and looking at them and being able to see what it looks like rolled out into your simulation environment. We're going to take our first break at this time. It is now 7:05. We'll take our 15-minute break and we'll be back at 7:20. Okay, and I'll put that in our chat box here, okay?
I did find an article, by the way, that talks about that whole Confederate thing and whatever. Anyway, this one was from 2020, but it was talking about Pam Jeffries' like simulation theory and whatnot, and that they were noting that there were so many different terms being used, right? And so they identified a universal term, simulated participant, to describe all the human role players within, who've been trained and whatnot, which I thought was interesting. Close to.
Well, how about put that in our chat box and everybody can get it?
Sure.
Put that in our chat box and everybody can get that as well. Thank you, Kristen, and I will also take that one and put it in our resource box. There it is. Thank you so much. Pause.